Good afternoon and welcome to the Davies Use Case webinar being presented by Lafayette General Health on sepsis. This is a Davies Award-winning use case for the value of health IT. My name is Arnold Simmons and I'm Manager of Quality and Patient Safety, and it's my pleasure to moderate this presentation. Promoting the use of health IT to improve the quality of healthcare delivery. Advocate the integration of clinical decision support and best practice guidance, access clinical data to analyze progress, and IT-enabled patient safety tools for the healthcare organization, clinicians, patients, and community members as vehicles for improving patient outcomes. The HIMSS Nicholas E. Davies Award of Excellence is the pinnacle of the HIMSS Value Recognition Program. The Davies Award recognizes outstanding achievement of organizations from around the world who have utilized health information technology to improve patient outcomes and value. The Davies Award-winning use cases have been peer-reviewed to validate sustainable, improved patient and business outcomes resulting from health IT-enabled care delivery. It is my pleasure to welcome our speakers for today's webinar, Taylor Hargrave and Dr. Emanuel. And I'll turn the presentation over to you all, and thank you for being here today.
Our journey to improve sepsis using health information technology. My name is Doug. I am the Chief Medical Information Officer for Lafayette General Health. I've been with the organization for about 8 years as an internal medicine hospitalist, and in my current role for about 5 years.
My name is Taylor Hargrave. I'm a registered nurse by trade. I've been a nurse for 6.5 years and 6.5 years at Lafayette General Health. I've been in infection prevention, being the infection prevention supervisor for the previous 3.5 years.
So, a little bit about who we are. We have 7 inpatient facilities covering a large area of our community. We are an ambulatory site. And because we are a large community-owned hospital, we have a significant number of independent medical staff. We have over 1,700 community medical staff members throughout our system, and only about 70 of them are employed by our organization. This really presents an interesting challenge whenever we want to put through initiatives, and we have worked through that quite well this time around. Patients and the volume of visits that we do throughout the year. Patient systems journey as we became more automated throughout the years. In and our CDI and PSI 15 processes into 2015, we continue on and continue to get more automated as we go throughout the years and have more coming in 2018. Local problem, we had to first determine what our overall mortality rates were specifically for sepsis. That was somewhat early detection, but it wasn't very discriminating. We used something called the rules of 100, where we would consider the temperature, the heart rate, and the systolic blood pressure. If a patient in our system had triggered the 3 of these on one patient, we would have a printout happen in the ICU that was monitored by a rapid response nurse or team member. At that point, they would take that piece of paper and determine whether or not they needed to go evaluate the patient and speak with the patient's primary nurse. It wasn't very discriminating for certain patients. We would also often get repeat alerts on the same patient over and over again, and it wasn't the most effective way for us to be alerting if somebody was, in fact, having some early signs of sepsis. To understand our contributing factors for our community. With higher unemployment rates in our area compared to the national averages, we have a lot of patients that end up with access to care and they don't have good health benefits. This results in a lot of times patients waiting to seek treatment or unable to get treatment earlier on that they would like to, therefore presenting to the hospital in a sicker state. The sepsis mortality rate and incident counts in our organization, specifically at our main campus hospital. We were able to see our mortality rates overall for the hospital were 2.13%, and we have the breakdown of the sepsis mortality rates based on the different levels of sepsis. A percentage of our mortality attributed to sepsis of over 33%. This is spanning our baseline November 2014 to 2015. Counts by diagnosis group. You can see that we had a monthly average of about 77 patients that had sepsis, and the breakdown following that of sepsis, severe sepsis, and septic shock. DRGs for each one of, for the counts and monthly average per DRG. We had quite a few. The highest number was in the DRG 871, which is severe sepsis without mechanical ventilation with a major comorbidity. We have length of stay. Our hospital-wide average length of stay time frame was 4.5 days. We also had significantly longer sepsis length of stays in all different categories of their illness. Time that we first started our journey, we were not very compliant with the CMS sepsis bundle that was put out at only 2.44%. So we had a long way to go in order to improve our compliance. We also per DRG at baseline. It's no surprise to anyone that caring for these patients with sepsis is very costly. We really needed to understand how an early detection system could make an improvement on length of stay, quality, and lower cost. So, and governance of our project. This to us because we were implementing a crawling algorithm into our EMR that would pull data from different parts in a meaningful way before any of the clinicians could make all of the connections together. That was very exciting for our organization to finally be utilizing health IT in a way that was very valuable for us. The project started with the executive sponsor, the CMIO, who is myself. We also had the Clinical Transformation Committee overseeing this project. That committee is chaired by the CMO of our main hospital. It's made up of physician department chairs and physician service leaders, also HIM, the Quality and Outcomes Department, nursing, and case management. This committee reports to the Medical Executive Committee on quality initiatives, tackling issues of outcomes and documentation, and peer review findings. Our project team included also the quality department, IT analysts, numerous nursing subject matter experts, clinical pharmacists, and Cerner quality reporting department. Our goals and our outcomes anticipated were simply to increase early detection and prevention of sepsis, ultimately leading to a decrease in morbidity or mortality. Our plan is 14 months. In the middle of our project, we ended up having to shift gears and consider the CMS bundle, which became a requirement for reporting during our project. So that lengthened our time frame a little bit. We initially built our alerts in silent mode, and the project team audited and validated every alert that happened on our patients for about 3 months. This auditing and information gathering led to populations of patients that we decided to exclude for a few different reasons. For example, our cardiovascular surgery patients had a lot of early detection warnings going off that simply were related to the fact that they underwent a very difficult surgery and were quite unstable in the initial 24 hours post-operatively. So we eliminated them for the first 24 hours. Interestingly, we found many of our actively laboring patients were triggering for things like elevated respiratory rate and elevated heart rate, and were by no means becoming septic. They were simply having a baby. So we eliminated them for 24 hours. Our patients were eliminated for the duration of their stay. And our project really focused on adult patients, so it wasn't exactly built for the variations in that a pediatric population can show. Out of all of the first two exclusions, it was only determined to exclude them for 24 hours because they were still a vulnerable population that could become sick later on. Consider was who to alert, and that one is a difficult consideration. The hospital, we have physicians that are in and out all day long and not necessarily in the electronic health record all day. So they were not the best population to pick up on an early detection system. We, our nursing staff, as well as our rapid response team and our resident physician population. We have the frequency of alerts to be determined at once every 24 hours, and they would be suppressed if there is a sepsis order set in place or a sepsis diagnosis in place for 72 hours. We also had to decide upon when to call a physician after a detection went off. Auditing, not every patient that was alerting was needing a physician intervention, so we had to determine through our physician committees how best to handle that situation. We are adding FTEs to our organization in response to this project. Our system was naturally growing as it was, and our main campus became a level 2 trauma center in this time frame, increasing the amount of high acuity situations between our stroke program, our trauma program, and the sepsis alerts as well. And this necessitated an FTE in order to accommodate those alerts and those high acuity patients. The physician community really felt that if we wanted alerts to be handled appropriately, we wanted critical care nursing oversight for the decision making on these patients. Lactate orders, so that if any lactate result was greater than 2, then we would get an automatic timed lactate for 5 hours later, just to ensure that that measure wasn't missed. That were in silent mode prior to go live, we found quite a few that were related to an infectious and a non-infectious etiology. We took these further to evaluate what the etiologies were. When we look at the infectious etiologies, the majority of them were coming from respiratory illnesses, and urinary tract infections, as well as documented sepsis. So these were naturally some of the higher likelihood infections that would be leading to sepsis already. Non-infectious etiology diagnoses of those patients. Quite a few of them were falling into our sickle cell category. A bunch of them were in GI bleed situations. We had many that were post-operative for a variety of surgeries, some cardiac, pulmonary, trauma, and end-of-life situations as well. This is where we got some of our data to determine the suppression criteria, but ultimately felt that it wasn't the right thing to do to exclude any of these populations because these were also very vulnerable for becoming sick with sepsis based on their underlying comorbidity.
We did assign education modules in our own electronic learning software. Assigned to all bedside nurses, so emergency department, all through ICU, including the med-surg floors. We are LSU as a major teaching hospital, provide our residents with education via their own electronic learning platform. That take care of a large proportion of our inpatients. And so we did attend hospitalist meetings just to kind of provide some education, not only about the alerts, but also about the new core measure. So the new core measure and the alerts were kind of rolled out simultaneously. To help with elements of this core measure, we did create and provide our hospitalists with a quick reference card, which consisted of bullet points for the severe sepsis and the septic shock bundles. For education to our medical staff, did attend the women's meeting, as well as several other medical staff meetings, including including the ICU subcommittee. And of course, all those roll up into the medical executive. So education module 1 month prior to go live. So we didn't want to assign it too far in advance so that it could be forgotten, but we also wanted to give them enough time so that they had time to complete it and not feel rushed, and everyone had the chance to complete it before go live. Quality abstracts core measure patients every month. We're able to see our total population and who passed the core measure, as well as who failed the core measure. So we really wanted to make it a point to take that as a learning opportunity or sent to the department leader. So if the patient missed while they were in the emergency room, we provide that information to emergency room leader. And same thing for ICU and for all the different floors. Just our misses, we also wanted to highlight our accomplishments. So we did that by sending our physicians thank you cards that had patient information and just as a thank you from the quality department on completing all of these bundle elements. And kind of managers at the bottom of the screen. And I think an important point is the investigation, which shows us exactly when time zero occurred and why we missed. So, to the opportunity notification. So this is sent to the physician who is responsible for that patient at the time of the miss. bundle elements that are required to pass the core measure, and also list specifics for that particular patient. When time zero occurred and why we fell out of the core measure spec. To the right side is an example of the thank you card that we would send to the physician if everything was passed. So, IT utilized. Well, any type of advanced crawler system. Important aspect for us to be able to use predictive analytics to help us treat our patients earlier. Learner crawls through the system looking for different types of vital signs, lab results, which is displayed on the next slide, but it's based on an algorithm. And when that algorithm fires, based on vital signs lab results within a certain time frame, it does generate an electronic alert. When that alert fires, that drives a task that's sent to nurses. This goes on their task list as well as their order screen. So it has to be acknowledged. We have different types of order set depending on where the patient was currently. So we do have a septic shock order set, which might be more directed to your ICU admit, which might have vital signs Q1 hour, as opposed to a basic sepsis order set that may have the vital signs Q4 hour. So depending on the acuity and location of the patient, that would determine which order set you would use. One of our pre-selected order sets was that we were able to collaborate with our intensivist group as well as our clinical pharmacy group to see what we could rely on based on the core measure specs as well as our local antibiogram core measure reporting, because it was a lot easier to see what was needed for the core measure bundle by using these order sets. And it was also easier to abstract for the quality department. Actual algorithm that's used to determine when an alert fires, and you can see there's it's quite complex, but mainly based on vital signs and lab results. And there's also several exclusion factors for things like diabetes and blood glucose, or failure with your creatinine. This is patient workflow project. We knew that how the patient presented, whether that would be via EMS and the emergency department, or whether they might have been here for a week or two and maybe post-op or presently in ICU, that those two pathways would have to be different a little bit. Just because current workflow in the ED is very different from current workflow in the ICU, and we knew we'd have to treat those patients differently. So this patient workflow and in the subsequent slide. ED workflow. So you'll notice ED is quite a bit shorter. ED seems to be a little bit more concise, and a lot of your stakeholders are already present there. Whereas a patient on the inpatient floor, there's a lot more channels of communication that we might have to go. Whenever meets all the criteria to fire an alert, there are two different types of alert. The first alert, which is based on your service criteria. So you have your systemic inflammatory response symptoms, and then on the other spectrum, you also have organ dysfunction alert. It looks quite similar to the sepsis alert, but what it does is it's a pop-up to a few people, including the primary nurse, the charge nurse, and it will tell you exactly why the patient is alerted. For instance, elevated heart rate or elevated temperature. There is a link to open the patient's chart from here. So in order to receive this alert, you do have to have that established relationship to this patient, whether that be the primary nurse, the charge nurse. But you don't actually have to be in the patient's chart. You really just need to be in the Cerner application. So if you're in Cerner and the patient's chart is not open, you will still get this pop-up alert. So again, the difference being that you do need an organ dysfunction criteria to trigger a sepsis alert. The sepsis alert is the only one that fires to our response nurse beep. So we did add one FTE, which is a rapid response team member type of a role, which has a beeper at all times across all shifts. And as soon as a sepsis alert fires on a patient, that's an alert to trigger on our response nurse beeper and indicating where the patient is and indicating that it is a sepsis alert. And the nurse goes to whatever unit the patient is on, and between the primary nurse occurs and necessary. And response nurse beeper with a 417. Does fire an actual order. And this order has to be reviewed just like any other order is. And it does trigger a task on the nurse's task list that also has to be reviewed. So even though the physician doesn't get contacted for every single alert does get acknowledged by the nurse. Have some discussion about when was appropriate to contact the physician. As we could see in some of the previous slides, we did have roughly about 50% of our alerts that may not have been infectious related. And so we did want to limit those calls to make this a successful program. That critical nurse assess the patient in addition to the primary nurse. So we did create a simple algorithm just to help guide the nurses as to, is it really necessary to contact the physician, or do we definitely need to call that physician in the middle of the night? Very important, because we do also have a young nursing staff. And the provider notification form. So the physician, we always want that to be documented. And we want to document why the call was placed, as well as what the orders were. See, we can document the name of the clinician, as well as document that we called for a SIRS or a sepsis alert. That's used in the emergency department and not have pop-up alerts for patients being treated in the emergency department. Do base almost all of their care off of this tracking board. It's on at the nurse's station. So we elected to use icons, the SIRS alert, as well as the sepsis alert. And we do have a resource nurse that rounds in the ED and nurse of this patient if she sees the icon. And the prime follows up on all sepsis icons with the treating physician, and then the resource nurse discusses these icons with the primary nurse. that we had previously mentioned. For ED, which is an ED treatment protocol, as well as a severe sepsis, septic shock one, and a med sepsis one. And we do also have a brief sepsis order set. So we started the program that whenever we would pick up septic patients that were already admitted, they already had such as your intake and output, maybe your fluids or a diet. And so whenever our nurses were putting together and blood cultures from that physician for this patient that was already admitted, it was set to go through. So we did create a brief order set, which just had very basic sepsis treatment orders such as lactate, blood cultures, fluids, things like that. That way it was a lot quicker to use and a lot more efficient for our inpatient. What we did add to all of our order sets and so sepsis quality measures is basically a trigger that when this order is placed, it adds different tasks to the nurse, such as your lactates and blood cultures to the care company. And so this provides an easy, quick reference for the primary nurse to make sure that everything gets accomplished in the time frame that it should. Identification was a good way for the physician that places this order to document what type of sepsis it is. I think that challenges that a lot of hospitals have faced with this core measure is identifying when exactly time zero is. Identified by different labs and vital signs if you have a suspected source of infection. And it could also be identified by physician documentation of severe sepsis or septic shock. And what this order allows us to do is to discreetly capture that documentation. So the physician can document severe sepsis present, septic shock present, or neither, if it's just a basic sepsis. And page. Sometimes it's hard to put together trends when you're looking at different things like vital signs and lab results that might all be in different places in the patient's chart. And what this allows us to do is to look at everything that goes into the St. John's alerting algorithm in one screen, as well as when your sepsis alerts fire. And it's a lot easier to notice trends. And it's also helpful for our quality department to abstract if they're looking for time zero and trying to see how far away was the elevated temperature from the systolic blood pressure. It's very easy to get those timestamps by looking at this one screen. And what exactly triggers this specific sepsis alert? And so if you're looking and you do see a sepsis alert, you can always double click on it and see exactly what triggered it.
For a little bit about the value that was derived from this process that we put into place. Combined data, we did see a significant decrease in our sepsis mortality in all categories and in our overall hospital mortality rate. Actually, averages from one measurement period to the next, you can see our percent change in our mortality rate. We had double-digit percent change in mortality in all of our categories. Some of them were quite significant, up to 50% in our severe sepsis. Overall, we had over 5% decrease in mortality attributed to sepsis in our population. measure compliance, we were at 2.4% at our baseline and went up to 25.86% during our measurement period. And at the time of this recording, we're up to 40% compliance at this time. As an increased incident count and coding of our sepsis patients. Between the early warning system plus all of the education that was being done and the ability to treat the patients with more defined criteria, we were recognizing sepsis and SIRS on an increased basis, and also the early detection system seemed to be shifting our recognition to an earlier state of sepsis rather than severe sepsis or septic shock. And our DRG coding from a decrease in our sickest group and an increase in our sicker and sick group, likely reflecting the early detection system. Even on an increased number of patients that had sepsis, and we're shifting the population with earlier detection, we maintained our length of stay throughout all of our sepsis and our hospital-wide. Evaluate our cost per case. We a decrease in the cost, presumably by detecting these patients earlier in their sepsis infection. We were able to impact their progression of their disease and spend less money taking care of them. We were coding more patients, and as you can see, you can pick up that we saved over $340,000 in cost savings over these DRGs between the baseline and the measurement period. We were improving our efficiencies to care for the patient and lowering our costs overall. The real made that is most closest to us is the impact that we had on lives saved. The change in the mortality from the baseline times the number of patients, the number of sepsis encounters that we had, you can see how we impacted almost 40 lives over this measurement period. We look at these as lives saved from sepsis by putting in the early detection warning system. Considerations to work through. We have some challenges still in the emergency room when we have a sepsis diagnosis that has not been made upon the initial presentation of the patient. We have to figure out how we're going to capture that time zero more accurately. We're looking at likely doing this with a combination of nursing documentation, identifying sepsis that could pull into the physician's notes and contribute to the overall diagnosis. We'll work with our intensivist and the CMS criteria to evaluate changes in the Surviving Sepsis campaign as they adopt new criteria. We'll likely have to change our alerting system over time to keep up with regulations and evidence-based medicine. A few changes on our icons that are firing in the emergency room that need to be updated to accommodate employees that are colorblind and have difficulty differentiating between the SIRS and the sepsis alert. And as we have moved to an organization of 7 hospitals, we're also including our chief medical officer with the physician opportunity letters to help address misses that we have. As you recall, we're a community-based hospital, and this is an effective way for our physicians in the community who are not necessarily part of our medical staff all the time to get education on the measures that are out there by CMS and the impact that we have made with the sepsis early detection system. Well, we was helped helpful to understand our journey to implement an early detection system for sepsis and our outcomes that we are very proud of. Thank you for listening.
Thanks for that great presentation. Thank you for joining us for the Davies webinar. More Davies use case webinars and information on how to apply for Davies Award can be found posted at HIMSS Davies Award website at hims.org/Davies. Thank you so much. I thought that went pretty well.
You don't?
Yeah.